Hi, everybody. Today, I'm going to be talking to you about the causes, the pathophysiology, and management of small bowel obstruction. So what is small bowel obstruction? Like the name suggests, small bowel obstruction, there is an obstruction in the intestine that prevents bowel contents to pass from the small bowel to the large bowel. So what are the causes? So the causes can be divided into mechanical obstruction and functional obstruction. In mechanical obstruction, there is a physical barrier that causes the obstruction. For example, adhesions, neoplasms, Crohn's disease, which is an inflammatory bowel disease. So recurrent inflammation results in stricture formation, which can cause obstruction. Intussusception, where one bowel loop telescopes into another. Parasitic infections, and foreign bodies. In functional obstruction, there is a problem with peristalsis. So the causes here are opiates, post-op, and hypokalemia. Types of obstruction. So you have a open loop obstruction and closed loop obstruction. In open loop obstruction, there's only one portion of the bowel that's obstructed. And in closed loop obstruction, there are two sites where it's obstructed. Also, in closed loop obstruction, there can be vascular compromise. So there's increased risk of ischemia and infarction and necrosis of the bowel. So what is the problem here in small bowel obstruction? So the obstruction causes the proximal portion of the bowel to dilate and the distal portion collapses. The dilation is mainly because of buildup of partially digested food, gas, swallowed air, and intestinal secretions. And this dilation stimulates peristalsis. And peristalsis is what causes the patient to vomit, causes nausea, and loose bowel movements as well. A further buildup of fluid in the bowel causes increasing a bowel wall permeability. So that results in third spacing of fluid. So the third spacing of fluid combined with the vomiting, the poor oral intake, results in hypotension, dehydration, and electrolyte depletion. Also, the buildup of partially digested fluid and stasis of the bowel contents is like a perfect environment for bacterial growth. And this bacteria can also enter the bloodstream and cause sepsis. So how does it present? So they classically present with an abdominal pain, which is crampy in nature, a crescendo, decrescendo pattern, abdominal distension, nausea, vomiting, constipation, obstipation. There can be a history of recent surgery or radiation therapy. On examination, the patient will have generalized tenderness and decreased bowel sounds. These are the early presenting features you can find. And later on in the disease, you can see fever, worsening abdominal distension, absent bowel sounds, and peritoneal signs. So from this, you can tell that the symptoms are quite vague. There is no particular clinical feature or physical finding that can like rule out the disease or anything. So, it presents like very similar to every other GI illness. So you have to combine both, clinical features and diagnostic findings for you to diagnose the disease. So how do you diagnose it? So the lab tests you can order are WBC, BUN, and creatine. So BUN and creatine can tell you about the volume stats of the patient. You can also get lactate, which is increased in case the patient has ischemia or infarction going on. And this happens very later on in the disease. So your imaging options include abdominal X-ray, CT scan, and ultrasound. So the best out of all these three that you can use in the emergency department is ultrasound. It's not only easily available, but it's also better in performance. It has a very high sensitivity and specificity. It's almost as good as a CT scan. So abdominal X-ray is rapidly available and can be easily performed. But the reason it's not recommended is because there are a lot of false negatives. And CT scan, the problem with that is it's quite invasive and unnecessary radiation exposure. But CT scan is very helpful in diagnosing complications of the disease. like ischemia, infarction, and it can also help you find out the transition point or where like the obstruction begins. But ultrasound is all in all best that you can use in the emergency department. So what are you going to see in the abdominal X-ray? You'll see dilated bowel loops and multiple air fluid levels. In CT, you will see dilated bowel loop of more than 2.5 centimeter. You can find signs of ischemia and infarction. That can, so you can diagnose that based on the contrast. So if there's ischemia, the bowel will not take up the contrast, as you can see in this picture, and a viable bowel will take up the contrast and the bowel wall will be enhanced. So the recommended technique is CT abdomen and pelvis with IV contrast. Theoretically speaking, oral contrast does sound like a good option. You think it will show you the exact point where the obstruction begins. But also remember, the bowel is filled with air, fluids, undigested food. So the oral contrast might not reach all the way till the actual obstructive point. So it has a very low point penetration. So it's not going to give you the right transition point. So IV contrast is best because it also helps you diagnose, the complication of ischemia and infarction. But the best test you can do is ultrasound. So in ultrasound, you're looking for abnormal peristalsis, which is basically back and forth movement of the bowel contents. Normally, bowel contents are supposed to move only in one direction. And dilated bowel of more than 2.5 centimeter. Here, the magic number is 2.5 centimeter. Both CT and ultrasound, you're looking for a bowel diameter of more than 2.5 centimeter, suggests obstruction. And then keyboard sign is seen in this picture right here. Is basically just the bowel contents that can be seen in the keyboard-like, finger-like projections. And the type of probe you can use in ultrasound is a curvilinear probe. The best approach is to start looking for the bowel in the right and left lower quadrants. Anterior approach is not recommended because, the abdomen is distended, it's probably filled with air. So you start from the sides, it's much easier for you to locate the bowel. And watch out for false positives, because small bowel obstruction is not the only thing that can cause a dilated bowel. You can also see dilated bowel in gastroenteritis, diarrhea, ileus as well. So I do have a video that I can play for you. 1 second. So this is just a small 3-minute video that describes how the ultrasound can be used to diagnose small bowel obstruction.
Hello everyone, I'm Jacob Avila of 5 Minute Sono, and this is how you scan a small bowel obstruction. Now, as far as which probe you should be using, I would start with the curvilinear probe. It's got the best combination of resolution and penetrance into the body. You can also use the phased array probe, but your images won't look as good. If the patient's skinny enough, the linear probe would work just fine. When you actually place the probe on the patient, you can put the probe wherever you want. However, I would suggest starting in the right and left lower quadrants. The reason for this is that a lot of small bowel obstructions are going to have air fluid levels, air layers anteriorly, and if you look anteriorly first, you're only going to see the air, which is going to be represented by A lines. However, if you start kind of in the right and left lower quadrants, a little more lateral, you're more likely to see the fluid in the small bowel obstruction. When evaluating a patient for small bowel obstruction, if they don't have a small bowel obstruction, often you won't see any bowel at all. You'll just be seeing the air represented by A lines. Occasionally, however, you will be able to see normal bowel in a patient without a small bowel obstruction. This is what normal small bowel looks like. You can see the feculent material inside of it really only moving in one direction. If we actually go out and measure it, we can see that it is below our threshold of a small bowel obstruction of 2.5 centimeters. Like I said earlier, you can use your linear probe if the patient's skinny enough. This is what normal bowel looks like with a linear probe. If you look at the tick marks on the side here, and kind of extrapolate, you can see that the bowel is less than 2.5 centimeters as well, and it's completely collapsing. This is what abnormal looks like. We can see multiple loops of dilated small bowel, and if we look up here and down here, we can see a little bit of abdominal free fluid, which indicates a poor prognosis. When we actually measure this out, it measures 3.9 centimeters, which is above our cutoff of 2.5. Sometimes you'll be unable to see the classic image of multiple loops of small bowel. Sometimes you'll only be able to see one loop like we see here in this picture. If we were to measure this loop out, we would see that it would be greater than 2.5 centimeters. However, there's a secondary sign that we can see here, and it's the flecks of feculent material that are moving back and forth. What this means that there's an obstruction distal. The bowel is trying to push against the distal obstruction, and the stool, instead of going just in one direction forward, it's kind of going back and forth. Besides seeing peristalsis and the back and forth movement of the feculent material, you might actually see the opposite sometimes. You might see dilated small bowel that's barely moving at all. This patient here also has a small bowel obstruction. As I mentioned earlier, if you remember one number, remember 2.5 centimeters. If the bowel diameter is greater than 2.5 centimeters, suspect a small bowel obstruction. There are a couple of other signs you can look for. You can look for wall thickness greater than 4 millimeters. You can look for decreased or absent peristalsis, or back and forth stool movement, as we mentioned earlier. The Tenga sign is seen when there is free fluid around the small bowel obstruction. The free fluid often takes a triangular shape. The Tenga sign was not named after a great clinician or a prolific researcher. It was named after a type of bikini. To recap, your preferred probe for this kind of examination is going to be a curvilinear probe. You want to look in all 4 quadrants, but I would look in the lateral lower quadrants to start with. That would be kind of your most specific area. And the number that you want to remember is 2.5 centimeters. My Twitter handle is @ultrasoundmd.
1 second. So go back. So yeah. Now talking about management. So the basic management for airway, it's quite uncommon for your patients to have airway compromise. Patients with closed loop obstruction can be septic and unresponsive. And for circulation, so they are vomiting, and there is that spacing of fluids and also port intake. So they will be volume depleted. So you can give your patients isotonic fluids like saline, Ringer's lactate, and electrolyte repletion. Particularly watch out for potassium. And directed management. So surgical consult is necessary, especially for patients with evidence of clinical deterioration, signs of peritonitis, and CT findings of bowel infarction and ischemia. So should you use an NG tube? So traditionally it was recommended, but there's not much evidence to support its benefits. So you can use an NG tube if your patient has intracerebral vomiting, severe abdominal distension, altered mental states, or other risks of aspiration. You can give your patient antibiotics if they have signs and symptoms of sepsis and hypoperfusion. So the complications you need to look out for are perforation, ischemia, and infarction, and sepsis. So the key points for you to remember from this entire presentation is that patients with small bowel obstructions, they have vague abdominal complaints. There's no specific history or symptom that's going to help you rule out the disease. So always match the clinical features, history with the ultrasound findings. And ultrasound is the best test you can do in terms of both accessibility and performance. And don't forget the magic number, 2.5 centimeter. And early surgical consult and laparotomy is very crucial in treating these patients. And as always, thank you so much for listening. It's been a pleasure.